Good evening. Thank you for viewing our poster. My name is Dr. Jessica Heintz.
And I'm Dr. Olivia Wong.
We are both family medicine residents at Honor Health Scottsdale Osborne near Old Town. We had a very interesting case of West Nile virus on our inpatient teaching service that we thought would make an excellent poster. So the title of our poster is West Nile virus, a neglected tropical disease of Arizona, ? Something to ponder. Dr. Wong is going to get started with the introduction.
So West Nile virus is a mosquito-borne virus that was first reported in the U.S. in August of 1999. Since its introduction to North America, it has caused an estimated 7 million cases of infection and is the leading cause of domestically acquired arboviral disease in the U.S. Most cases are subclinical or cause mild symptoms. Less than 1% of cases are more severe and may cause neuroinvasive disease such as meningitis, encephalitis, seizures, and/or acute flaccid paralysis. Advanced age is the most significant risk factor for the development of neurologic disease. The first confirmed case of West Nile virus in Arizona occurred in 2003. Arizona usually experiences a biphasic season with cases in early August and then late September. However, in 2021, experienced significant higher average rainfall between the months of July and September and resulted in a larger mosquito population. In 2021, there were 472 confirmed and 1,095 suspected cases in Arizona. This is the highest amount ever recorded for the state. Of those cases, 65% presented with encephalitis or meningitis. So for our patient, she is a seventh decade of life with history of hypertension, COPD, hypothyroidism, and aortic aneurysm, presented for shortness of breath and fever. She had intermittent worsening, shortness of breath, and confusion for 7 days, and then developed fever 2 days prior to admission. There was associated symptoms of nausea, diarrhea, and anorexia. Pertinent negatives included headache, chest pain, palpitations, abdominal pain, urinary difficulties, and lower leg edema. It was noted later that she has been gardening outside recently and likely experienced mosquito exposure. No sick contacts nor travel were noted, and patient was not vaccinated against COVID. At baseline, patient was fully independent and still driving, but family member did note gradual memory loss for 3.5 years with no formal diagnosis of dementia. So on her physical exam, for her vital signs, she was afebrile at 99.1, heart rate 88, respiratory rate 18, blood pressure 133/83, setting 94% on room air. Patient was laying in bed in no acute distress, tremulous, slow to respond, but no dysarthria. Cardiac exam, regular rate and rhythm with no murmurs. Pulmonary exam, clear to auscultation bilaterally, no wheezes, no accessory muscle use. For skin and musculoskeletal exam, skin was warm, dry, intact, lower extremities without edema, with mosquito bites scattered bilaterally. Neuro exam, alert and oriented ×3, no focal deficits, cranial nerves 2 through 12 intact, strength +5 out of 5 in all extremities, with negative Kurdic and Brudzinski sign.
So for her hospital course on day 1, she was admitted and monitored overnight while the initial workup was pending. A bacterial or viral infection had been suspected, but based on initial labs, the etiology was still unknown as things were pending.
On day 2 of her hospitalization, she had acute change in mental status with episode of desaturation to 70% O2. A rapid response and stroke alert was called. O2 improved with jaw thrust and 6 liters of O2 via simple mask. ICU transfer did not occur given DNI status. She was stabilized spontaneously without any other interventions. At this time, neurology and infectious disease was consulted. CT brain had no acute findings. She underwent a lumbar puncture with presumptive negative meningitis and encephalitis panel. Pulmonology was also consulted and recommended a nasal trumpet, with her underlying COPD likely attributed to her hypoxia and her hypercapnia, also possibly her confusion.
So on day 3, she unfortunately had a second rapid response called with another acute change in mental status. This time she required up to 15 liters of oxygen via non-rebreather to maintain oxygen saturation. Significant tachypnea with respiratory rate into the 30s also developed. The patient was placed on BiPAP, but once again she stabilized spontaneously. The remainder of the hospital course, days 4 through 6, there were continued episodes of respiratory status fluctuating up and down with needs for supplemental oxygen, but unfortunately by day 6 the patient was stable on room air and fever also resolved and confusion improved as well. By day 7 the patient was back to being ANO times 4 with mentation at baseline per family members. The patient was diagnosed with a diagnosis of meningoencephalitis of unknown etiology. West Nile virus serum and CSF were still pending at that time. The patient was sent to SNF for continued recovery, and then after discharge, the West Nile virus serology resulted.
Now we will go over some of her labs and imaging. So for serum, she had a leukopenia. On day 1, it was normal at 6.7, but it dipped down to 3.4 by day 5. For her West Nile virus serum antibody results, she was positive for IgM at 6.97.
For the CSF studies obtained through a lumbar puncture, the CSF had no growth, and the meningitis encephalitis PCR panel was presumptive negative. For the CSF studies, there was a neutrophilic pleocytosis with a total of 227 total nucleated cells, 34% of which were neutrophils. There was also elevated glucose at 78 and elevated protein at 138. Most importantly, for the West Nile virus CSF antibodies, the IgM was detected for the West Nile virus.
So for her imaging and other studies, her CT brain without contrast showed no acute intracranial abnormality. This was repeated another extra time and was also negative. Her MR brain without contrast showed no acute infarct or intracranial hemorrhage. An EEG was completed that showed moderate generalized swelling.
So in Arizona, West Nile virus did reach an all-time high in 2021 due to heavy monsoon rains. This caused the confirmed and probable West Nile virus cases to increase 801% in comparison to 2019. 2019 was previously the year that it had the highest number of cases. Fortunately, the majority of West Nile virus cases are asymptomatic or subclinical. That's about 80 to 90% of those cases. But as we mentioned earlier, you can get severe neuroinvasive disease in less than 1% of cases, and unfortunately the elderly are most at risk for developing this severe neuroinvasive disease. Mortality from West Nile virus neuroinvasive disease is approximately 12%. And then in Arizona, there were 110 deaths that occurred in 2021, which was a 479% increase from 19 deaths caused by West Nile virus in 2019.
Our case demonstrated a classic presentation of neuroinvasive West Nile virus in an elderly patient with comorbidities. West Nile virus is a vector-borne virus transmitted primarily from mosquitoes to humans. Transmission via breastfeeding, blood transfusion, and transplanting West Nile virus infected organs can also occur. Incubation period ranges from 2 to 14 days. The patient likely became infected with this virus while gardening several days prior to admission, resulting in her encephalitis and episodes of acute flaccid paralysis with associated respiratory failure.
To diagnose West Nile virus, it is a laboratory diagnosis, and that's typically done using serum and CSF to study or test for West Nile virus, IgM. It is important to note that West Nile virus IgM antibodies typically take 3 to 8 days to develop after illness begins and can actually persist for up to a year or more after initial infection. That being said, serial studies of serum and CSF West Nile virus, both IgG and IgM, may be necessary to help distinguish an acute infection from a prior infection. Unfortunately, treatment only consists of supportive care primarily at this point in time, and the frequency and severity of long-term sequelae are still unknown, but can include movement disorders and cognitive problems. So West Nile virus was once a novel pathogen, but now we need to consider it as something that is endemic and can have significant clinical and economic impacts in Arizona and throughout the United States. Theoretically, age-based vaccination is potentially the most effective method to combat West Nile virus. As we mentioned, advanced age is the most significant risk factor for neuroinvasive disease. But at this point in time, no vaccine currently exists, and no vaccine trials have passed phase 2 of preclinical research. Due to the significant impact of severe West Nile virus cases on the healthcare system and economy, we do need or would benefit from more grant funding and research, both for a preventative West Nile vaccine, especially for the elderly, and for effective therapeutic agents for patients who do have acute neuroinvasive West Nile virus. In the interim, what should we be doing? First and foremost, clinicians need to be considering and testing for West Nile virus in patients, even in an outpatient setting, especially for those patients who present with fever and neurologic symptoms. This is important because it will help us better calculate the incidence and prevalence of West Nile virus to potentially lead to that increased funding for grants and research. Another thing that remains important is prevention, especially via community level mosquito control and household or personal measures to avoid mosquito bites, whether that's wearing long clothes, using mosquito repellent. Since West Nile virus may disproportionately affect vulnerable populations, such as the elderly or those who are struggling with housing insecurity, it also occurs in climates that are conducive to mosquito-borne disease and can be controlled by vector surveillance, and finally is inadequately addressed by both clinicians and policymakers. West Nile virus can arguably be considered the next neglected tropical disease.
So to take a look at our map over here in the center, we can see it's a total number of West Nile virus cases that are neuroinvasive by county from 2009 to 2018. We see Maricopa County here is at an area that is fairly high. And that kind of concludes our presentation. Thank you so much for listening, and we have our references at the bottom for your reference. Thank you.